Set your sights on subcutaneous and intradermal injections. In this presentation, various aspects of subcu and intradermal injections will be discussed. Let's begin by taking another look at this cross-section of the layers of body tissues. It is important to have a good understanding of where the injectable medication is going. The dermis is the second layer of skin beneath the epidermis. Intradermal injections are deposited here. Underlying the dermis is the subcutaneous tissue. The literal meaning of subcutaneous is under the skin. Nurses frequently give subcutaneous injections. Insulin and anticoagulants such as heparin and Lovenox are a few of the more common ones. Let's first turn our attention to the subcutaneous injection. Subcu fast facts. The subcutaneous tissue is not as vascular as the muscle. Injections are absorbed more slowly here. Due to the decreased vascularity of the subcutaneous tissue, aspiration is not necessary. The likelihood of striking a blood vessel is very low. The subcutaneous tissue cannot tolerate irritating medications. Subcu medications are non-irritating, non-viscous, and water-soluble. Subcutaneous sites include general areas of the body where the subcutaneous tissue is more generously distributed. Think of subcutaneous sites as zones or regions, and the intramuscular sites as bullseyes. Greater precision is required with intramuscular injections due to the depth the needle is inserted and the major nerves and blood vessels that are in and around the muscle. The best subcutaneous sites include the outer aspects of the upper arms, the abdomen from below the costal margins to the iliac crest and avoiding the umbilicus 2 inches all the way around, and the anterior thighs. Less commonly, the dorsal gluteal area, the fatty tissue above the buttocks, posterior to the love handle region, can be utilized, and lastly the scapular region of the back may be used, but it is not one of the more common sites. If a patient is very thin and has little peripheral subcutaneous tissue, the abdomen is the site of choice. Let's take a closer look at the subcutaneous injection nuts and bolts, or in other words, the practical and essential details. The recommended needle length and gauge for subcu injections is 3/8 to 5/8 inch, 25 to 27 gauge. Insulin needles are even smaller yet, 5/16 to 1/2 inch, 28 to 31 gauge. Due to the frequency of insulin injections, these smaller needles help prevent skin-related complications. The maximum volume the subcutaneous tissue can absorb per injection is 2 milliliters. Subcutaneous needles are often pre-attached to the syringe, such as in the case of insulin syringes and some anticoagulants. In general, the nurse pinches the tissue at the injection site in order to elevate the subcutaneous layer. The angle of insertion for subcutaneous injections is either 45 or 90 degrees. The nurse factors in the patient's weight, the site selection, and the needle length when deciding whether to inject the needle at a 45 versus a 90-degree angle. Using a 90-degree angle on a very thin patient could deposit the medication into the muscle. Conversely, a 45-degree angle on a patient with a significant amount of adipose tissue or with a very short needle could deposit the medication superficially and into the upper layers of skin. Again, the nurse must critically assess which angle will deposit the medication correctly into the desired layer. In the nursing lab, we have a general rule of thumb to help guide you. If the nurse can pinch an inch of tissue, inject the needle at a 45-degree angle, and if 2 inches of tissue can be pinched, inject the needle at a 90-degree angle. If the patient is obese or if the needle is very short, such as with newer insulin needles, there is no need to pinch the tissue at all. The nurse supports the skin across the injection site by spreading it tightly between the thumb and index finger and then injects the needle at a 90-degree angle. Insulin is a very common subcutaneous injection. Here are some basic facts about insulin that will help you manage it safely. Insulin lowers blood sugar. It is given in type 1 and sometimes type 2 diabetes. Insulin is classified as a high alert medication. High alert medicines are drugs that bear a heightened risk of causing significant patient harm when used in error. This classification sends an extra warning to the nurse to be very careful. In some agencies, a second nurse must verify the accuracy of the insulin dose before it is given. Insulin injections are given in the same anatomic location for consistency of absorption. This allows patients and doctors to better predict insulin needs. In a given anatomic location, for example, the abdomen, the injection sites are rotated within. There are 5 types of insulin. Insulin is categorized into types according to the period of time it works in the body. The nurse must know and understand the onset, peak, and duration of each type of insulin. The onset is the amount of time it takes the insulin to start working, or more specifically, how soon it will start lowering blood sugar. The peak effect is when the insulin is working the hardest, and the duration is the length of time the insulin effect lasts in the body. Understanding these parameters is imperative to patient safety, as the timing of an insulin injection is critical to its correct administration. The nurse plans insulin injection times based on blood glucose levels and when a patient will eat. So in the hospital, before giving each dose of insulin, the nurse must know the patient's present blood glucose and, for mealtime insulins, when the patient's meal tray will arrive on the clinical unit. Without this knowledge and awareness around the timing of insulin, the nurse can cause a life-threatening hypoglycemic reaction if rapid or short-acting insulin is given without food. The information on this slide compares the onset, peak, and duration of the insulin types. This chart was taken from the Perry & Potter 8th edition Skills Manual. It is included in this presentation for your reference. Please note the onset of the rapid-acting insulins. Keep in mind this type of insulin starts lowering blood sugar almost immediately. This is why in the hospital, when it is given for mealtime coverage, it is not given until the meal tray is with the patient. Similarly, short-acting insulin will start lowering blood sugar in 30 to 60 minutes after administration. With this type of insulin, typically the patient begins consuming the meal approximately 30 minutes after the insulin is given. Please note also that when preparing insulins, long-acting Lantus and Levemir cannot be mixed with other insulins in the same syringe. Anticoagulants such as heparin and Lovenox are common subcutaneous medications as well. Lovenox is a low molecular weight heparin. These medicines are given to reduce the incidence of thrombus formation in patients with risk factors. Before administering anticoagulants, assess the patient for signs of bleeding and also for any pre-existing conditions that would contraindicate its use. The recommended site for subcutaneous anticoagulants is the abdomen, avoiding the umbilicus 2 inches all the way around. Administer the medicine slowly to prevent tissue trauma and bruising, and patient permitting, leave the needle in the tissue 5 to 10 seconds post-injection. This will prevent leakage of the medication at the injection site. Intradermal injections. Intradermal injections are typically given for skin testing, for example, allergy tests or tuberculosis screening. Because such medications are potent, they are injected into the dermis where the blood supply is reduced and absorption occurs very slowly. Since intradermal tests are often looking for allergic response, this slow absorption prevents an anaphylactic reaction to a possible allergen. To administer an intradermal injection, a 1 milliliter TB syringe with a pre-attached 25 to 27 gauge, 3/8 to 5/8 inch needle is used. The needle is inserted into the tissue very superficially at a 5 to 15 degree angle, and it is advanced approximately 1/8 of an inch under the skin. You will actually see the needle tip through the skin. The maximum volume the dermis can tolerate is very small, up to 1/10 of a milliliter. Intradermal sites include the ventral surface of the forearm and the scapular region of the back. A bleb at the injection site is an indication that the medication was deposited into the dermis. Never disturb the bleb by applying pressure or massaging it. This could cause the medication to disperse or leak. If no bleb is observed with intradermal injection, the medicine was likely deposited too deeply into the subcutaneous tissue. This could cause test results to be invalid. Here you can see the bleb that occurs on the surface of the skin. It resembles a mosquito bite. This concludes the presentation on subcutaneous and intradermal injections.